So question number 1, the following combination is incorrect. To understand this question, see, let's read the options first. Reticulocytes is stained by methylene blue. Actually, the right answer should be new methylene blue. The best answer must be here, new methylene blue. But let's take this option as correct only. Why we take it correct? Let's see the other options here. Heinz bodies are Leishman stain. Look, Heinz bodies are actually seen in GCP deficiency, and Heinz bodies are nothing but these are oxidized hemoglobins. So because there are oxidized hemoglobins, they can stain surely by the Leishman stain. But the best stain for them is not Leishman. The best stain is a reticulocyte stain. The basophilic stippling can be stained right stain. The best full name of right stain is the right Dbmci stain. And Howell jelly body can also be stained by this Romanowski stain. Now, I understand that many of you might be lacking a few concepts on what are these stains and how are these stains useful in the general practice. So what we'll do is we'll just try to understand what is this Romanowski stain. See, Romanowski stain is a combination of acidic plus a basic dye. Okay? The acidic dye and basic dye means it's a combination of eosin plus methylene blue. It's a combination of eosin and methylene sorry, eosin and methylene blue. So basically, the examples of Romanowski stain, they are right stain, right Dbmci. You can also name them as Jenner Dbmci. Okay, Jenner Dbmci. The other examples of this is Leishman stain. Okay, Leishman stain is one more example. So all of these stains are example of Romanowski stain, and all of them are used in general hematology. But when we move to the supravital stain, the supravital stain are basically used to stain only and only reticulocytes. Please understand this thing. The supravital stain basic role is to stain for a reticulocyte. This should be clearly, okay, it should be very clearly understood. Okay, it should be very clearly understood. The basic role of a supravital stain is to stain a reticulocyte. So, when you talk about a supravital stain, there are three examples. The basic stain is used for reticulocyte, but it can also be used to stain the Heinz bodies here. But the example of them are very important. 1, 2, and 3. They are new methylene blue. NB means new methylene blue. Okay, NB here means new methylene blue. It can be then the brilliant chrysal blue and crystal violet. So the best answer to this question should be B. Why? Because Heinz body are stained not on the Leishman stain, but they are stained on the supravital stain, which are new methylene blue, brilliant chrysal blue, and the crystal violet. The three good examples of the supravital staining. Okay? Let's move to next question. Which anticoagulant is used to send the blood sample for a complete blood count? Well, CBC is a complete blood count, and you all might have worked as an intern or house surgeon in a ward, and you use what? This vial to send a CBC sample. If I ask you what the vial you use for serum, looking for serum chemistry, LFT, KFT, you take these two for serum LFT, KFT, which is either yellow or can be red. So to understand this in a better way, what we'll do is we'll try to make a small list of the anticoagulants and what are the uses of those anticoagulants here. Okay, let's try to make a list of that. So what is the answer you have marked? First of all, what is the answer you have marked? Please be interactive. Fatapat. I'll not be asking you again and again to answer this question. You should see the question and just write the answers. Okay, there you go. So look at the color, look at the anticoagulant and the usage of these. Color wise, let's start with the purple color, which has dipotassium EDTA. The basic use is to send for CBC sample. Then there is black color and the light blue color. So black color and light blue color both have trisodium citrate, both have trisodium citrate, both of them have the same thing. The difference is in a black color use a ratio of 1:4, whereas the blue color you raise a ratio 1:9. Okay, the basic use of this black color is to send a sample for the ESR, but the blue color is used to send a sample for coagulation, like the prothrombin time or the activated partial thromboplastin time, all can be used for D-dimer testing. Now this can be one question, because dimer has been a lot of sample which are sent in a COVID days, and therefore dimer is an important question that can be asked from this. Okay, apart from this, it can be green in color. So green color have lithium heparin in it. Okay, the green color is lithium heparin. The green one is lithium heparin. Now this is basically used to send a sample of electrolytes. Some labs will also send a sample in ABG for this, and a few of them will use a sample for sending for the osmotic fragility testing, OFT. Okay. Then comes the gray color. It is a gray color, which is potassium oxalate, and sodium fluoride is used. Potassium oxalate and the sodium fluoride is used, and the basic use is to send a sample for sugar. Now this can be asked as sugar glucose, same thing only. Okay, now this potassium oxalate is the anticoagulant, whereas sodium fluoride here is an enolase inhibitor. So this enolase inhibitor is important, because if you do not put this sodium fluoride, then what happens, the glucose will be used up and be declining throughout the time. So to decrease the glucose breakdown, it is used to sodium fluoride is used as a anticoagulant mixture there. Okay, then you can use either this yellow color or the red color. Both of them don't have any anticoagulant, but difference is yellow has a clot activator. Okay, this is important. Yellow one has a clot activator, and they both are used to send a sample for serum. Serum means like the liver function test or the kidney function test or any lipid profile, hormones, all of them can be used to send a sample in this red, yellow or the red ones. So this is the basic list of everything that can be asked on this topic. Ensure that you know every word of this one, because this is a very, very important list. I can vouch on the fact that in exam that you are appearing, this is a very prominent set of questions that the examiner has. He wants to look whether you have ever went to a ward or not. So ensure you have went or not, but you know this table. Okay, guys, is it okay? Nature lover, Herobal, Kevin, Anke, Shahjans, Pallavi, be active और active रहना पड़ेगा. Okay, so these all are the examples that you should and should know, must and must to know. Okay, now this is a question that has been already been asked in few of the exams. So fetal hemoglobin, consider the following chains. Dekho, if you look at the fetal chains, there are chains like alpha 2 and the gamma 2, then alpha 2 and the delta 2, and alpha 2 and the beta 2. Okay, alpha 2 gamma 2 is HbF, alpha 2 delta 2 is HbA2, and alpha 2 beta 2 is HbA. Okay, so these are all the hemoglobin which can be there. The HbF means fetal, and these two are adult. This is fetal hemoglobin, and these both are called as adult hemoglobin. But if the question is what is the amount of or percentage of these in the adult hemoglobin, remember HbA2 is 2.5 to 3.5%, HbA is 96.5 to 97.5%. Okay, and F in a fetal stage is obviously most prominent, but if you talk about the HbF in adult, so in the adult stage HbF is less than 1%. Now these three again becomes a very frequently asked question. So fetal hemoglobin is what? Alpha 2 and gamma 2. Alpha 2 and gamma 2. Okay, they are alpha 2 and they are gamma 2. These two again becomes very, very important question. ये क्या है? It is HbA. Alpha 2 delta 2 क्या है? It is HbA2, and this is not a valid combination at all. ठीक है? And this one is alpha 2, gamma 2 is the HbF. This one is the HbF, which is being asked in this question, ठीक है? Please, before we move ahead, I want you all to be active. How many of you are actually watching this video? Can we have this presence Present sir. How many of you are there? Please share the video also so that your friends who are also preparing for the FMG, upcoming FMG in December, they also get benefited. And if you like the video, it will really helpful for all of us. Okay. चलो. Yes sir. Presence sir. कितने लोग present है? रामेश्वर प्रेजेंट है, आरएन प्रेजेंट है, केविन प्रेजेंट है, शुभम, हर्षिल, Heroval. Why I'm talking this name? Because I will take all of your name when you get a FMG cleared in December 2021. All of you, I want to be there. Heroval, Pallavi. Who else? अरे present बोल दो. Don't answer anywhere else. अभी तो present बोल दो. चलो आगे बढ़ते हैं. The cell marked in the image is present in which of the following conditions? बोलो बोलो. So which cell mark ही नहीं किया हुआ है? This cell, the big one, center. Look at the color here, guys. This is a big cell. First of all, you agree it's a big cell, but the color is not pink, not blue. It's a combination of blue and pink. Such cell which is a combination of blue and pink, they are called as a polychromatophil. Okay, polychromatophil. Okay, we got some more presents. Om Prakash, Tania, SS, Ala. Okay, Shubham has already cleared, but thank you for Shubham for your comment. Harshil and Pavan. So anyway, this is not only for FMG preparation because the exam is clear that we are just calling it FMG, but this entire test and discussion is for anyone who is preparing for any exam in the PGME days. It can also be used for DM preparation. Okay. So this cell is actually what? It's a polychromatophil, also called as a reticulocyte. It's a polychromatophil, also called as a reticulocytes. So as you all know, reticulocyte is seen in which condition? It is seen in hemolytic anemia. Okay, what are the other conditions you can see? See, polychromatophil can also be seen whenever you are giving a patient a therapy in case of nutrition anemia. For example, if you give iron treatment, TT means treatment, TT by T means treatment in iron deficiency anemia, or you give say B12 or folic acid treatment in the megaloblastic anemia. Okay, so whenever you are giving these treatment in case of these anemias, the moment you give them this treatment, the more and more cells get produced in the bone marrow, and when they're produced, they release out of the bone marrow, and that is what causes this entire thing. So for example, the options, the cell marked in the given image is seen as the following. Yes, it can be seen post iron therapy. PNH is again a case of hemolytic anemia. Which type of hemolytic anemia? Intravascular. And hemolytic anemia is obviously the answer. So the best answer is D. Best answer to this question is D. Okay? The best answer to this question is D. Not A, B or C separately, but the best answer is D here. Okay, the best answer is D. Did you get the point, all of you? Bawa bujha ki nahi batao. You are so much quiet as if there is some exam going on. There's not an exam, it's a pre-exam. Be interactive. Chalo, next question. A 20-year-old old male comes to the OPD with the complaints of blood in urine. Okay, he has generalized weakness, fatigueness, and yellowish color of skin. That means he has anemia and jaundice. Anemia and jaundice. He added that the last week he has an episode of malaria and was given treatment for it. A patient who is having anemia, he's having jaundice, he had a fever of malaria or whatever, malaria, and he was given treatment for it, which means for malaria you give what? Chloroquine, primaquine, sulfadoxine, all of those you give. And after 3 days, he has anti-malarial therapy, he has blood in urine. Matlab, what is happening? I hope you got it correct. Yes, he is having hemoglobinuria. Okay, this is showing you he is having hemoglobinuria. And these are findings present here. Retic is high, which proves is a case of hemolysis occurring. Proven it's hemolysis. Okay, the blood smear is showing you Wow, wow, wow. So beautiful test. Look at this RBC. Look at this one. क्या है ये? It's a bite cell. Perfect. It's a bite RBC. Okay, it's a bite cell. ठीक है, this is normal RBC, and this is a bite cell. Now, what are these? These are reticulocyte. They are reticulocytes. क्या है ये? The reticulocytes. And what is the stain being used? As I mentioned in the first question, it is stain used is supravital stain. And what is this? G6PD deficiency. G6PD deficiency. And what is the inheritance pattern? Yes, it is X-linked recessive more than autosomal recessive. Other question that can be asked, it can show you bite cells. What are these? They're Heinz bodies, okay? They're Heinz bodies. They're Heinz bodies. You can also see what? Blister RBCs. Okay? Blister RBC can also be seen in the G6PD deficiency. And therefore, the best answer to this question is X-linked recessive. Okay? X-linked recessive is the best answer to this question. X-linked recessive is the best answer to this question. Okay? कोई डाउट है तो पूछो. And doubt still now? Chalo, let's move further now. I advise you to share this video to others also who are preparing as a friends. If anyone is preparing for the FMG, please ask him also to join the sessions, because by the end of today's class, I can assure that the person will have a good revision of the entire pathology. I can assure you that. But for that, let's ask more of your friends to join. Whether you are a FMG preparing student or you are a PG preparing student, please ask your friends to join the session so that we can have maximum interaction to start with. Question 6. A 16-year-old female, Reena, is brought to emergency room presenting with high-grade fever, chest pain and dyspnea. Okay? She gives a past medical history of 2 hospitalization for abdominal pain, which resolved with medication and hydration. Well, she has a hematocrit of 23, which means she has anemia, and a retic count of 9. The moment you get anemia, this is showing you what? Anemia. And this is showing you what? She has hemolytic anemia. Hemolysis going on. Well, the patient dies in hospital and autopsy spleen is firm and brown. Well, this shows a case of a firm small spleen with a hemolytic anemia. She also has a history of chest pain, and she has a resolving with medication and hydration. Well, these all are given histories in the MCQ, and they all are probably what? Yes, you correctly guessed it. Sickle cell anemia. Yes, it's a case of sickle cell anemia. Now, those who are wondering, sir, why it's a case of sickle cell anemia? Please understand, this becomes a case of hemolytic anemias. Now, in the evidence of hemolytic anemia, which of them will respond to medication or hydration? Which of them responds to medication or hydration? It's a case of sickle cell anemia. Well, what is the basic pathophysiology there? So sickle cell anemia, it has a mutation in the beta chain. This is a very important question. In the beta chain at the 6th, beta gene I should say, not the chain, 6th position, where glutamic acid is replaced by valine. The acid is negatively charged and valine is neutral amino acid. So in short, what happens, if you remember, that suppose there is a normal hemoglobin A. Okay, the hemoglobin A is like this, but hemoglobin S, especially the deoxygenated form, deoxy-HbS, it becomes with a sticky patch like this. Now all the sticky patch will join to each other like this, and this becomes a long polymeric chain. Okay, they become a long polymeric chain. The A and A is separate, but when they become S, they all stick to each other, and this becomes a long polymer. So this polymer is the biggest problem, because inside the RBC, when such polymers are there, these polymers will damage these RBCs here. Now, because they damage it, many RBC will stick to each other. This polymer will damage the RBC membrane. Because they damage the RBC membrane, so all these RBC will join to each other like this. Okay? So the flow of the blood will decrease here. And because the flow will decrease, it will lead to ischemia, what is called as a vasoconstriction. vaso-occlusive crisis. A vaso-occlusive crisis. This vaso-occlusive crisis most commonly, okay, remember this is very important question. क्या कहते हैं? What do you call this? We call this vaso-occlusive crisis. Now here comes a question, very important. Listen to me carefully. The most common symptom is a painful dactylitis. Okay, the most common symptom is a painful dactylitis, but it can also lead to increased infections which can occur in the bone by mostly Salmonella typhi, or can occur in the chest as called as acute chest syndrome, also called as acute chest syndrome. Now remember that these two will always respond to IV hydration. Okay, this is again very important in oxygen therapy, because these respond, they surely call as reversible sickling, even though there are many other findings in the vaso-occlusive crisis. And what are those? The other finding which you must remember, they are like it can lead to kidney failure by causing papillary necrosis, okay, in the kidney. They can lead to retinopathies, right? Retinopathy. They can also lead to stroke in the brain. Yes, stroke in the brain. So all of these actually, these all three, they actually are other symptoms, but these will not respond to the IV hydration and oxygen. So what responds to IV hydration is the pain and infection, which is given in the MCQ. Later on, they can lead to what? Autosplenectomy. Autosplenectomy, right? And if the question is, what is the treatment? The first treatment is here. What is that? IV hydration and the oxygen. But what you can else give? You can ask the patient to avoid the infections, number one, and you can also give hydroxyurea, because hydroxyurea will increase HbF and therefore decrease sickling. Okay, one more treatment for this is hydroxyurea. Okay, and why? Because it will increase HbF, and high amount of HbF will decrease the amount of sickling. This is again very important. This again is very important. Okay? Achha. Now based on this question, see, when there is a later down stages, it can also lead to hemolysis. Later on, it can also lead to hemolysis, that is called as irreversible sickling. And what type of hemolysis? It can lead to extravascular hemolysis. In fact, remember, it also has small amount of IVH, intravascular also. In sickle cell anemia, you have both intravascular and extravascular hemolysis both. But if the question is, what is the best treatment? It should be hematopoietic stem cell transplantation. That's the best treatment available for sickle cell anemia. And how to diagnose it? You diagnose it by peripheral smear. Yes, simple peripheral smear. If not found, do a sickling test. What else? You can also do IV hydration to ho gaya, antibiotics ho gaye, and you can also give what? As a diagnosis one, it can give hemoglobin HPLC. But again, if it is asked what is the best way of diagnosis, it becomes genetic mutation analysis. Please understand, the moment you have a question of best way of diagnosis, even you have an option of HPLC, don't choose that. The best way is or should be a genetic testing in which you can look for the mutation analysis in these cases. Okay? Chalo. Next question. Let's read the question. A 12-year-old boy comes to OPD with his mother with complaints of generalized weakness, fatiguity, yellowish color skin and eyes, weight loss is few months. So he has again what? He has a case of anemia and he also has a jaundice occurring there. On examination, hepatosplenomegaly was found and hemoglobin is 8, again proving anemia, and 12% means he has hemolytic anemia, no doubt about it. There is peripheral smear shows the following results, and there is osmotic fragility. And what are these cells? I hope you all guessed it correctly. It is spherocytes. Remember this. How can you say the spherocytes? So whenever you get an RBC like this, first of all, try to look at a normal RBC. This is a normal RBC. It's a normal RBC. See, if you look at a normal RBC, they have a clear looking central pallor. This is a pallor. This white area is a pallor. And this whole pink area here is a normal RBC hemoglobin. Now, normally this is pallor, but if you compare this RBC to these RBCs, do you get any pallor? No. The size is small, and therefore it is what? It's a case of a spherocytic RBCs. Look at the question above. Now, this question is giving you The OFT lysis was less than 0.7. We'll talk about this separately also. And the liver function test is showing you increase in the bilirubin, which is obviously the true in case of any hemolytic anemia. They always have jaundice. His mother added, a year back his father also suffered from the same illness. That means there is some inheritance, right? Okay. The most common cause of disease is, what is the question telling you? It's a case of hereditary spherocytosis. And what is the most common defect? Bolo? It is ankyrin defect, more than band 3, more than spectrin defect. These are the main defects what can happen in a case of hereditary spherocytosis. Remember, the case is autosomal dominantly inherited. It's autosomal dominant inherited. So this in short what happens, these all three are proteins. What are these three? Ankyrin, band 3, spectrin. What are these? They are proteins of the RBC membrane. Because of this what happens? The membrane, whose membrane? Obviously RBC membrane, they break. And because they break, the normal RBC with a biconcave shape will change to a spherocyte like this. Okay, the spherocyte don't have surface area, and therefore when they pass through spleen, they will get hemolyzed. So the spherocyte will lead to extravascular hemolysis. EVH means extravascular hemolysis. And the reason the patients always have jaundice, they have splenomegaly. Okay, and that is the case. Now therefore remember, in clinically, when the patient have this extravascular hemolysis going on from the lifetime, because it's, remember, it's autosomal dominant. So what happens? The patients surely have a history of gallstones, they have spherocytes, and they also have, yes, splenomegaly. Now if I ask you what type of gallstone it is, what is the answer? It's a pigmented gallstone. Very good. It's a pigmented gallstone. Why it's pigmented? Because it basically consists of bilirubin. Yes, it consists of bilirubin. Well, what is the most common type of gallstone? It's mixed gallstone. Then what comes? Cholesterol gallstone. And least common otherwise is pigmented. But in HS, what you see? The pigmented type of gallstone is more common in a case of hereditary spherocytosis. Okay? Achha. Now, see, how do you diagnose a case? You can diagnose a case by first of all doing a Coombs test. Why do you do Coombs test? Because you see, if I ask you what are the DD of a spherocyte, this question is very frequently asked. The spherocytic DD, it can be HS, it can be G6PD deficiency. Okay, what else? It can be a case of, this is important, immune hemolytic anemia. It can be severe burns, or can also be toxins, Now, because it can be immune cause, because this can be immune cause or can be the other causes, the first thing you should do is do a Coombs test. Now, if I ask you, what about the Coombs test in case of hemolytic anemia, you should say, sir, Coombs test in HS will be negative, G6PD negative, burns toxins negative, but in immune cause, it comes positive. Okay? Yes, this is called as AIHA. Very good. It's called as autoimmune hemolytic anemias. So Coombs test is negative in HS. Next test क्या करोगे? Osmotic fragility testing, OFT. Okay, OFT. But please understand, OFT is not done nowadays. You have to remember two things here. In those two things, remember, OFT may you should remember that increased fragility is seen in spherocyte. Okay, and reduced fragility is seen in microcyte. Now these two information you must remember. A spherocyte is more fragile, a microcyte is less fragile. This is very, very important. Okay, so this is the OFT, but we don't do OFT nowadays. So the best way of diagnosing again is, when you ask the best one, just remember one thing, it should be genetic, matlab mutation analysis. Mutation analysis is the best way of diagnosing the case of HS. And what mutation you can guess? You can get a case of, see, most commonly ankyrin, then band 3, and the spectrin deficiency can be seen as a mutation in the hereditary spherocytosis. One very recently available test is called as ECTA flow cytometry. Just remember, this is a new test altogether. If you can remember well and good, nahi to koi baat nahi. The ECTA flow cytometry is a test which is used to detect for, It is mainly used to look for the band 3 defect. Okay, it detects the band 3 defect in HS. Bus. Remember this thing. Okay, so remember, these are all the questions asked. Especially I'll ask you to remember this one. OFT is increased in spherocyte and decreased in microcyte. This is must and must to know. Whenever the question is best, just close your eyes and mark. It should be genetic or mutation analysis. End of the story. No questions asked. No questions asked. This is very, very important, guys. Do not ignore these statements. So, come to this question. It's a case of, yes, HS. And what is the most common defect? It is norspectrin and chirin. And what is the best way of detection? It is mutation analysis. Is the best way of diagnosing a case of hereditary spherocytosis. Next question. An infant was referred to a tertiary hospital when the mother came in with complaints that her child is very sluggish and not feeding properly. On examination, you find the child is pale and has not developed the vital stones. On checking for vitals, you find he has tachycardia, has rapid breathing, and spleen was palpable on examination. This is again a case of anemia, and anemia with splenomegaly till now. Now, mother shows the report which MCH is very low, MCV is very low, MCHC is also decreased. Why? What is the normal MCH? Normal MCH is 30. Okay, around 30 plus minus 2 is okay. Picogram. So this is not very much low, but look at the MCV. Normal MCV is 90 plus minus 5 FL. This is very, very low. It is now has gone to 40 to 75. And MCHC, it is normally 32 gram per DL. It has decreased also. So this surely is a case of anemia and a microcytic hypochromic anemia that is occurring right from the infancy. Remember, it's a microcytic hypochromic anemia. Why microcytic? MCV dekho na. So it becomes a case of microcytic hypochromic RBC right from childhood. So now you have to think about those microcytic and hypochromic RBC causes. What are the 4 causes you already know? Iron deficiency anemia, anemia of chronic disease, sideroblastic anemia, and thalassemia. Now tell me, among these 4 causes, which of these anemia will present with splenomegaly? Which of these anemia will present with splenomegaly? I hope you all guessing it correctly. It should be thalassemia. Yes. So a case of thalassemia with a splenomegaly, this proves it's a case of thalassemia. This is very, very important. And if you have missed it, no worries, but ensure that you understand what is the question trying to ask you. Okay? So look at the options here. Splicing mutation is the most common cause of the disorders. What do you say? Yes, it's true. Remember, the most common mutation in India for beta thalassemia is the intervening sequences IVS1 mutation, and this IVS1 mutation is also called as splicing mutation. Why? Because what is IVS? It is intervening, intron mutation. It's an intron mutation. Because of mutation in intron, the splicing is not normal. Okay? It's an autosomal dominant disorder. No. It is false. It is what? It is autosomal recessive. Remember, beta thalassemia is autosomal recessive. TIBC increases and transferrin saturation decreases in this order. So this is very important to understand. In a case of a patient who has thalassemia, thalassemia patients, they have more and more iron therapy given to them. Because they have more and more iron therapy given to them, later on there is an iron overload. I hope you remember in pediatrics also you might have read that in patients of thalassemia, you often give iron chelators. Why do you give them? To prevent the iron overload. You give deferoxamine, you give defepron. Why? Because these are iron chelators. And why do you have to give it? Because there's iron overload. So when there's iron overload, the TIBC will decrease and transferrin saturation will increase in case of iron overload. So remember one thing, in thalassemia due to repeated blood transfusion and increased iron absorption from GIT. These two causes leads to what? There is iron overload. Okay, this iron overload, and so because of iron overload, what you get increased ferritin levels, right? You get decreased TIBC levels, right? So and you get what? The increased transferrin saturation in percentage also. Increased transferrin saturation in percentage also. So these are all the three things you expect in what you expect in thalassemia. All three things you expect in thalassemia. This is again important, very important information. So look at this question again. The right answer is first one. What about HbF? HbF, this is normal. HbF is always increased in case of thalassemia, and hence this statement also becomes false. So let's understand how to understand and solve the question on thalassemia, because I have never seen an exam without a question on thalassemia. It's very, very frequently asked. Thalassemia, it can be alpha or can be beta thalassemia. So we talk about the beta thalassemia. See mutations here. First of all, mutation. In beta thalassemia, it can be number one, IVS1 mutation. It is a most common mutation. And this causes what? Beta plus chain. Beta plus. But if a patient has supposedly promoter mutation, they again have beta plus. But the moment a patient has a termination codon, that is stop codon mutation, it becomes beta 0. Okay, the mutation beta thalassemia. In alpha thalassemia, there is alpha gene deletion. This alpha gene deletion. And how do we write it? We write it minus. We just write it minus. We don't write it plus or beta plus alpha minus. We straightly write minus. Because there's deletion there, you write minus here. Okay, you write it minus here. Okay, now remember, because there is iron deficiency going on initially there is microcytic hyperchromic RBCs, so body will try to absorb more and more iron. This increased absorption from the GIT is what causes iron overload, and you also give more and more repeated blood transfusions, which also causes iron overload, and thereby causing the increased ferritin, increased saturation, and the decreased amount of TIBC in these patients. Okay, what else you know in thalassemia? Thalassemia shows some X-ray features. Remember, hair on end appearance, crew cut appearance, those all are finding seen in thalassemia only. This again is important. The X-ray features of thalassemia are hair on end appearance, and the crew cut appearance. These all are the features you see in thalassemia. Okay, they all are features you see in thalassemia. What are the RBC morphology you see in thalassemia? Again, that can be a question. So RBC morphology in case of thalassemia, this again is an important question. RBC morphology in thalassemia. First of all, remember, we'll show you microcytic hypochromic RBCs. What else? Target cells. What else? Nucleated RBC. Okay, what else? The nuclear remnants. The nuclear remnant of the RBCs. What do you call them? Howell-Jolly bodies. Howell-Jolly bodies. You call them Howell-Jolly bodies. Okay. These all are seen. Apart from what you see, basophilic. Okay, I just forgot one. Cabot ring is also seen. Cabot rings. Okay, Cabot ring is also seen. Then basophilic stippling can be seen. And you can also see some fragmented RBCs in case of thalassemia. Microcytic hypochromic are small RBCs with less color. Target cell is cell strain area. NRBC, nuclear fragments, Cabot rings, and basophilic stippling. So if you see a nucleus inside it, full nucleus, it is NRBC. If you see nuclear remnant here, Howell-Jolly bodies. If you see Cabot full ring here like this, it's a Cabot ring. And we see multiple ring here, okay, figure of 8 like this. So complete figure of 8 appearance. If you see light blue color dots here, it is called as basophilic stippling. A question can be, it is also seen in, answer should be, it's also seen in lead poisoning. It's also seen in lead poisoning. So we have discussed every question that can be asked on thalassemia. Every question that can be asked on thalassemia. How to diagnose it? You diagnose it by case of HPLC, and the best ways, mutation analysis. What happens in HPLC? The HB in beta thalassemia, remember what will happen? The HbA, A2 and F. A will decrease, A2 and F will increase. So simple. A will decrease and A2 and F will increase in case of thalassemia. But again, I repeat, the best way of diagnosing thalassemia is genetic mutation analysis. If you have that in the option, do not choose HPLC. Okay. Next question. A 45-year-old vegetarian woman has fatigueness, joint pain, and disturbed vision. She also has palpitations. On lab test, she has megaloblastic anemia and she has hypersegmented neutrophils. Now remember, she is vegetarian. Now because she is vegetarian and she has these features, it becomes surely a case of megaloblastic anemia. The few important diagnosis of this etiology, you all know, is either a B12 deficiency or can be folic acid deficiency. In case of vegetarian women, even though B12 is more common, but in vegetarian, see, vegetarian women, they have more folic acid intake. But in non-veg, there's more B12 intake. Okay? So B12 is mainly in the non-veg foods. You know this? B12 is mainly in the non-veg foods and the folic acid mainly in the veg foods. This again becomes very important. Okay? So, in case of a patient having hypersegmented neutrophils, it becomes what? It becomes a case of B12 deficiency anemia. Why it is not iron deficiency anemia? I'll show you microcytic hypochromic RBCs. What will lead binding show you? Will show you what? I just discussed in the previous question also. It will show you the basophilic stippling. And ACD will show you normocytic normochromic RBCs, may show you microcytic hypochromic RBCs, but ACD most commonly shows normocytic normochromic RBCs. This patient having hypersegmented neutrophils, this question, this word, and megaloblast, it surely becomes a B12 deficiency anemia. It becomes a B12 deficiency anemia. Next question. A 38-year-old male presents with complaints of generalized weakness, pale skin, headache, sometimes bleeding comes. On asking, it was found that he has undergone gastrectomy due to peptic ulcer. Okay? He has a blood pressure of 130/70, pulse of 70. He has decreased RBG lucidates. That means they have pancytopenia. Okay? She has what? She has pancytopenia. Looking at the options here, which of these four causes do you think can present with pancytopenia? Which of these four causes can present with pancytopenia? Well, obviously, IDA will always have anemia only. This also has anemia. This will have decreased white blood cell. But this will have pancytopenia. Simple. Aplastic anemia is a case where you get pancytopenia. Along with that, you get hypocellular bone marrow. So it's a case of bone marrow failure. Few inherited causes of aplastic anemia. This can be asked. It is Fanconi's anemia. Okay. It can be dyskeratosis congenita and Diamond-Schwarzman syndrome. The three inherited causes of aplastic anemia is Fanconi's anemia, dyskeratosis congenita, and Diamond-Schwarzman syndrome. Diamond Schwartzman syndrome. So right answer is aplastic anemia because there's pancytopenia and hypocellular bone marrow. Okay, hypocellular bone marrow. Okay, had this been a case of pure red cell aplasia, PRCA, then you would have got only a case of anemia, not pancytopenia. Okay, if this would have been a case of PRCA, then you would have got only anemia, not pancytopenia, with selective absence of erythroblast in the bone marrow. Okay, if this would have been a case of PRCA, then there would have an absence of erythroblast in the bone marrow. So let's now move back to the question and let's see why are the options not there. First of all, sir, why is this history giving you peptic ulcer and gastrectomy? Well, there's no need of giving this, but I gave you this question just to confuse you. Now look at the MCQ. Because the patient has aplastic anemia, see, it cannot be IDA, it cannot be ACD. Acute leukemia patients have increased white blood cell count. They won't have low white blood cell count. Okay. And now, can you tell me, does aplastic anemia have splenomegaly? No. Remember, aplastic anemia on examination, they never have splenomegaly. So if you get a case of pancytopenia and you get a case of splenomegaly, do not think about aplastic anemia. Okay? Well, remember this. This question is also asked in this year's of INICT. So I want all my students to take care of this statement. On exam, O by E means on examination, they never ever have splenomegaly occurring in a case of aplastic anemia. Next question. A 25-year-old female has abdominal pain, fatigueness, and weight loss diarrhea. From stool examination, there was hookworm infestation was made. The following will be seen on lab investigations. Bolo. What is it case of? It's a case of, yes, iron deficiency anemia. ID. In respect to the iron deficiency anemia, ferritin is low. TIBC is high. Saturation is low. And MCV is low. What is the right answer? It's B. Now, how could I get to understand it is iron deficiency anemia? Because the patient has anemia in the first line. And look at the second line. Hookworm infestation. Remember, hookworm causes what? Chronic blood loss. The chronic blood loss will cause what? Chronic blood loss causes what? It causes iron deficiency anemia. So what we'll do is, we'll try to understand a few scenarios based on the RBC morphology. So if ever you see a case of microcytic hypochromic RBCs, please understand one thing. Microcytic hypochromic RBCs, think about few things like iron deficiency anemia, thalassemia, sideroblastic anemia, okay, iron deficiency anemia, thalassemia, sideroblastic anemia, and what? Anemia of chronic disease. Anemia of chronic disease. So, differentiate them by doing serum iron studies. Now, I want you all to just make it very simple for yourself. Will not make the things tougher for us. Okay? Dekho. Serum iron, serum ferritin, okay, TIBC, and percentage transferrin saturation. Okay? Now we'll try to discuss what happens in different cases. At least we should know two of them, which is IDA and ACD. You know what is ACD? Anemia of chronic disease. Anemia of chronic disease. Okay? Anemia of chronic disease. Okay? Okay? IDA and ACD. IDA and ACD. ठीक है देखो, in iron deficiency anemia, a patient has, in iron deficiency anemia, patient has what? He has low iron. Ferritin is low. Okay? TIBC is high and ferritin is low. Remember one thing, the moment you get a case of TIBC and ferritin, they always are opposite. Make it very simple for yourself. A case of ferritin and TIBC, they are very, very opposite. Okay, they're very, very opposite. Ferritin and TIBC, they all are exactly opposite. So when you get low ferritin, you get high TIBC. Low ferritin and high TIBC. Okay, now you get to ACD. ACD. In ACD, low iron, okay, low iron and low saturation. But these two become exactly opposite. These two become exactly opposite. Ferritin is high and TIBC is low. Got the point? How to differentiate iron deficiency anemia with ACD? Exactly opposite. यहाँ low ferritin, high TIBC, यहाँ पर high ferritin and low TIBC. This is how to differentiate a case of IDA with anemia of chronic disease. Okay? Now in this question, it's a case of iron deficiency anemia. It's a case of iron deficiency anemia, and therefore these patients have what? They have a case of, देखो, ferritin is low, TIBC is high, saturation is should be high, so it becomes wrong, and MCV should be low because it's a case of what? It becomes a case of microcytic hypochronic anemia. Microcytic hypochronic anemia. Next question. Please read the question and tell me the answer. So, what is the answer? Okay, there is one idiot boy, GG Shorts. Is such students like these are the reason that everyone gets so pissed off, and like these type of students should never at all get anywhere into the a good practicing people, because the biggest problem of the medical science is that we don't even appreciate each other. How can you expect a patient to appreciate you when you can't even appreciate each other? So these students like the GG Shorts, who has just come from nowhere and doesn't know anything, they have just disturbing the entire thing. But let's not get distracted by him. Let's come back to our own reading. Shame on you. Okay. A 6-year-old female has splenomegaly, anemia and jaundice. On lab infestations, a patient has increased retic count, decreased serum haptoglobin, normal MCH. Okay, decreased MCV, increased MCHC. PS shows spherocytes. What is it? It surely is a case of hemolytic anemia, right? Hemolytic anemia. Okay, and what is it? It's a case of hereditary spherocytosis. It becomes a case of hereditary spherocytosis. And what is the most common defect? We have discussed this already. Most common defect is ankyrin. Remember, it is ankyrin more than band 3, more than spectrin. Some questions can also be asked, like among them, the maximum hemolysis. occurs in. Then the answer becomes alpha spectrin. Okay? If the question is most common defect in spectrin loss, it becomes what? It becomes a case of, yes, it becomes a case of hereditary elliptocytosis. These are very frequently asked questions. Please remember this. Please remember this. Okay. Next question. 8-year-old female has splenomegaly. Please answer this question. She has anemia, jaundice. Okay. So again becomes what? It becomes a case of extravascular hemolysis. On lab investigation, there is increased red tick count, decreased serum haptoglobin, which is proving what? Hemolytic anemia. Normal MCH, decreased MCHC, increased MCHC. So one is one thing to show that spherocytes, remember, a spherocyte is a case where you get increase in MCHC. This can again be a question. This can be again be a question. Okay. PS shows spherocytes. PS shows spherocytes. If we do OFT, what do you see? So OFT in a spherocyte is, I told you above also in previous questions, it is increased. Yes, it shows increased OFT. Had the question been of thalassemia and microcytic hypochromic RBC, it would have become decreased OFT. So make it simple for you again. Increased OFT, spherocyte, decreased OFT, microcyte. Okay. Let's move to the next question. Same type of question, but now the option is the following is not useful for diagnosis. So what I told you, in a case of hereditary spherocytosis, what a test you do? First of all, peripheral smear to prove spherocytes. Then what you should do? Coombs test to exclude what? Immune cause. Then you should do what? OFT. It should be increased there. And you can do what? ECTA cytometry to look for band 3 defect. Do you know what is the full form of Nestroft? Well, Nestroft is naked eye single test tube RBC OFT. RBC OFT. Okay. Naked eye single test tube RBC OFT. Naked eye single test tube RBC OFT. So what happens in the OFT is, see, this is actually a single test tube and the percentage NaCl in this is what? It is just 0.3%. This is again very important. In case of this one, in case of percentage NaCl, which is only 0.3% NaCl, 0.3% NaCl. So what we do is we take this NaCl test tube, and in this NaCl, the normal RBC is lysed, a spherocyte is lysed, but microcyte is not lysed. Please remember, in this concentration, microcytes are not lysed. Okay, microcyte is not lysed, and therefore it is used in screening of thalassemia. This is a very, very important question. It is used in screening of thalassemia. Nestroft is used in diagnosing a case of thalassemia, not in a case of a spherocytosis. Okay, so right answer is Nestroft. This is used in case of microcytosis and is used in screening of thalassemia, not in the other cases. Next question. Cytocyte, what is this called? It's also called as helmet cell. Helmet cell. Okay, like this. Helmet cell. So where do you see cytocytes? You see this in microangiopathic hemolytic anemia. It's used in a case of microangiopathic hemolytic anemia, MAHA. Okay? It's used in a case of microangiopathic hemolytic anemia, MAHA. So what happens in this cases? It is what? Dekho. This is a vessel And in the vessel, suppose you get these as a thrombus. Suppose there's a thrombus here. Okay? It's a small vessel, and in the vessel there's thrombus, and this RBC is passing through it. When the RBC is passing, it will get this RBC. Please understand, this is RBC, and this RBC is crossing this here. It gets this first defect, it gets broken. Again one more and gets more broken. Again gets one more and gets more broken. So ultimately the RBC, which is crossing through it, it keeps on breaking down like this. And what comes out is RBC like this. This typical RBC is called as a cystocyte. It's called as typically a cystocyte. And what is it seen? It is seen in capillaries or small vessels. And capillaries having what? Microclots. And therefore the name is micro, small vessel, angiopathic, hemolytic anemias. Why? Because this RBC has lysed. This RBC is called as helmet cell or a cystocyte. This is also called as helmet cell or also called as cystocytes. Okay? Helmet cell or cystocytes. Now you must know what are the other causes of helmet cells. What are the other causes of helmet cells? Dekho. So what are the other causes of microangiopathic hemolytic anemia? First, a microangiopathic hemolytic anemia, it can be seen in TTP, HUS. This can be seen in a case of parched. So March, hemoglobinuria, vasculitis, malignant, HTN means hypertension, and can also be seen in a case of APLA. What do you know what is APLA? Antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome. What is TTP? Thrombocytopenic purpura. HUS is hemolytic uremic syndrome. Okay, it can be also seen in March hemoglobinuria, vasculitis, malignant hypertension, APLA. All of these are the causes of MAHA. And MAHA shows what? The cystocytes are also called as helmet cell. Okay? TTP, HUS, March hemoglobinuria, vasculitis, malignant hypertension, and APLA. All of them can show you this typical pattern. Okay. Tough one, right? Read the question. A 16-year-old boy has come to the clinic and presents with weakness, pallor, and dyspnea. Okay? He gives a history of minor infections and sudden onset of chills, fever, and prostrations. So what do you get in the history? You get in a history there is weakness, there is pallor and dyspnea. That means he has anemia, he has infection, and he also has splenomegaly is absent. Thrombocytopenia is present. That means he gets a case of pancytopenia and there is no splenomegaly. First of all, what are you thinking? This is a case of pancytopenia without any splenomegaly. So what are you thinking here? Socho, there is a case of pancytopenia without splenomegaly. You must think about it should be a case of aplastic anemia by the history. Now suppose you don't know about these images. At least look at the image. Which of this image looks to be a case of aplastic anemia cases? Look at the first image. It's showing you what? These all are spherocytes. These all are spherocytes. This cannot be the answer because it's showing you a spherocyte. Okay, look at this one. It's a bone marrow aspiration biopsy. In this, these are what? These are adipocytes. Adipocytes fats, and there are cells here. And the cells have reduced. Look at the enormous amount of fat in this case. Normally, please understand, normal percentage of this should be 50%. Normally it should be 50%. What do I mean 50%? I mean the ratio of cell is to fat. It must be 1:1. Normally I mean this. But in this case you can see the amount of cells have reduced and the fat has increased. And therefore it becomes a case of hypocellular bone marrow. It becomes a case of hypocellular bone marrow. And where do you see hypercellular bone marrow? It can be seen in the case of aplastic anemia. This is the right answer. But why not other options? Look at this one. In this case, you see what? Look at the hypochromic RBCs. Look at the microcytic RBCs. So microcytic, hypochromic RBCs. It is seen in iron deficiency anemia. And look at this one. Again becomes what? Microcytic, hypochromic RBCs. And look at the pencil cells you see here. A pencil cell. Look at this one also. It's a pencil cell. Look at this one. It's a pencil cell. So all of them are pencil cell with the microcytic hypochromic RBCs. So these two, the C and D, are seen in the case of iron deficiency anemia. This one. Now, even if you exclude the answer, it must come as B only. Why? Because think about the case of aplastic anemia. Why? Because it's pancytopenia without splenomegaly, and this is the only image we see here is a bone marrow, and therefore the right answer here should be, it should be what? It should be aplastic anemia. And the right answer is B here. This is the right image for this. And how can I see the right image? Because here the amount of fat, these all are fat, right? These are adipocytes. The amount of adipocyte is more and the cells are less. Normally the percentage of the cell should be equal to amount of fats. ठीक है, समझ आ रहा है ना? These all are fat area. These all are fat area. Normally the fat area must be almost equal to the amount of cells, but here you're getting more of fat, less of cell. We call this hypocellular bone marrow. Okay, hypocellular bone marrow. And as we look at a 16-year-old patient, please understand one thing: the percentage is 100 minus age. So for a 16-year-old patient, the percentage of a cellularity should be 100 minus 16. It should become almost what? Almost 84%. But do you think this is 84% cellularity? Not at all. It is quite less than 40%. And for surely becomes a hypocellular bone marrow. Again repeat, the normal percentage cellularity for any age should be less than, 100 minus age. And it becomes 84% in a 16-year-old person. Next question. A patient has MCV 110, TLC of 2000, platelet count of 90,000. It becomes what? Macrocyte, low TLC, low platelet count, and shows giant metamyelocytes and band forms. Howell jelly body is also seen. What is this case of? Giant metamyelocytes. It's a case of straight away megaloblastic anemia. It straight away becomes a case of megaloblastic anemia. So why is this not a case of aplastic anemia? Because in aplastic anemia, you don't get megaloblast. This is not a finding in aplastic anemia. Okay, in aplastic anemia don't get megaloblast. Similarly, in this condition, you see sideroblasts. What are sideroblasts? These are the erythroblasts in which you find nucleus, and inside the around the nucleus you get what? Pink color spots like this, called as ringed sideroblasts. ठीक है? Why not IDA? In this you see what? Microcytic hypochromic RBCs, and you also don't get giant metamyelocytes. Right answer becomes what? It becomes a case of megaloblastic anemia because its typical history, giant metamyelocytes and band forms. Howell jelly body is also seen in megaloblastic anemia only. ठीक है? Okay. Next question. A 45-year-old male came in with complaints of breathlessness, with dizziness and sweating. On examination, he was pale with increased heart rate and respiratory rate. So surely he has a anemia going on. He is a known case of rheumatoid arthritis. And blood picture shows low hemoglobin, normal MCV, low serum iron. TIBC is almost high here. TIBC is 300. The following is true regarding the above case. What is your DD? First of all, look at the findings. MCV is normal. Okay. Serum iron is low. TIBC, I'll say is normal only because normal TIBC is 300 only. It's almost normal. Now, this case is a case of a known case of arthritis. Known case of arthritis, and he has anemia. A patient who has a chronic infection going on and has anemia. A chronic infection with a case of anemia. Often what it talks about? It talks about normocytic normochromic RBCs in a case of chronic infection. What is it? It's a case of anemia of chronic disease. So what is ACD? Please remember this. What is ACD? ACD stands for anemia of chronic disease. In this condition, what happens? It is interleukin 6 and a small amount of TNF alpha which will stimulate the liver cells, and the liver will release hepcidin. Okay, they increase ferritin, increase hepcidin, increased ferritin, and because of the high hepcidin, what happens? There is low ferroportin. Because of high ferritin, what happens? There is low TIBC. Why? Because there is decreased transferrin. So there is also low TIBC. This is what is seen in a case of ACD. Remember, ACD is the most common cause of anemia in hospitalized patients. Okay? ACD is the most common cause of anemia in hospitalized patients for any other chronic disease. So look at the options here. Interleukin 11 is a main cytokine? No, it is IL-6. Marrow is negative to Prussian blue? No, because of the high ferritin levels. High ferritin, marrow, this what is, it's marrow iron, right? So marrow iron is very, very high. It's not low, it's high here. Okay? So option B is also false. This is also false. Iron supplementation will be beneficial? No. In fact, the iron should be restricted in these patients because he already has high ferritin. So iron should be low given to these patients. So what is the treatment? They should be treated with steroids and antibiotics in case of chronic infections. It becomes a case of ACD, and yes, it's the most common cause of anemia in hospitalized patients. So please understand one thing. Nowadays you get a question which should be excluded on the options. Nowadays straight questions are not asked. You have to exclude the options one by one by looking at the history. Known case of RA becomes a case of ACD, right? It cannot be IL-11. It cannot be low iron stain. It cannot be iron therapy given because not a case of iron which is anemia. You're left with option D, which is the right answer here. Please remember, this is all other finding which you will expect in a case of anemia of chronic disease. The following coagulation factors are vitamin K dependent except. So what are vitamin K dependent factors? The 2, 7, 9, 10. 2, 7, 9, 10. What is the answer? 11 is the answer. And why are they called vitamin D dependent factors? Because apart from this, there are also protein C and S, right? Now, why are they vitamin K dependent? Because these come from, yes, they come from liver. First of all, they come from liver, but they're inactive. They come in blood. Now to activate them, you again require vitamin K as a cofactor. And this activation adds what? A gamma carboxyl to glutamic acid residues. Now when there is addition of this gamma carboxyl to glutamic acid residues, they all become activated. Vitamin K acts as a cofactor, and hence we call this vitamin K dependent factors. This happens where? In the liver again. Remember one thing, few questions here. This whole thing can be inhibited by a oral anticoagulant called as warfarin. Okay? And therefore, whenever the patient has vitamin K deficiency or in warfarin usage, what happens? There is decreased amount of 2, 7, 9, 10 CNS. But what happens among these? The factor 7 has the shortest T half. But 7 has the shortest T half. Because 7 has the shortest T half, So what happens? The first factor, please understand, in these deficiency, the first factor to decrease is factor 7. Okay? So what happens? It is increase in PT initially. This again can be one question. Remember, a better way of looking for PT is INR. A better way for looking for PT is INR. You all know, international normalized ratio, in which you divide the prothrombin of the patient divided by the prothrombin of the normal person, called as control, ratio to the power ISI. This is again an important formula for INR, called as international normalized ratio. International normalized ratio. INR is the name. For the right answer to this question, it is 11. Remember, 2, 7, 9, 10 are those, but 11 is not a vitamin K dependent factors. Next question. In PT test, the addition of calcium and tissue thromboplastin activates which pathway? So when you're doing this test, remember the two types of tests: intrinsic factor test, intrinsic pathway, and extrinsic pathway. Let's make it very simple and how to remember it. These two pathways are remembered as they both will combine on factor 10. They both will combine on 10 to activate to 10A. This is a common thing occurring here. So because this is a common thing, this 10 and 10A is a common pathway. Now how does the activation occurs? Dekho. 12 converts to 12A. Okay? 12A converts 11 to 11A. 11A converts 9 to 9A. And 9A with the help of 8A converts 10 to 10A. 9A with the help of 8A converts 10 to 10A. Ye clear hai? Acha. This conversion is brought about by, this conversion here is brought by kaolin in the lab and high molecular weight kininogen in the body. Kaolin in the lab and HNWK in the body. In extrinsic factor what happens? There is factor 7 converting to 7A. And this again converts 10 to 10A. Yaad hai? 7 to 7A and 10 to 10A. This conversion is brought about by tissue factor, factor 3. Okay? Called as tissue factor. Also in the lab called as thromboplastin. Thromboplastin is the name. Ab dekho. The 10A and onwards is very simple to remember. Just think like this. This is rule of half. And how to remember rule of half? 10 ka half, 5. So 5 helps in 5 ka half, 2. And 2 helps in 2 ka half, 1. So remember, in the common pathway, there's 10, 10 ka half, 5, 5 ka half, 2, 2 ka half, 1. As simple as that. So common pathway mein half rule. 10, 5, 2, 1. 10, 5, 2, 1. It's as simple as that. Okay. Now this factor 1A is then acted upon by factor 13A to make it a stable clot. Stable clot. 13A to make it a stable clot. Now remember how to look at the factors and the test you do. These are diagnosed by some tests. And how to remember? Two tests are there. You all know the name PT and APTT. PT is prothrombin test. Now PT measures the small pathway. Why? It's a small name and small pathway. PT is a small pathway. Extrinsic pathway plus common pathway. Small pathway, small name. समझ रहा है? Small pathway, small name. But look at this long pathway and a long name. APTT will measure what? Intrinsic pathway plus common pathway. Did you get the point? My point is PT and APTT. PT is small pathway, small name. APTT is long pathway, long name. Now, if you look at this question, the question asking you calcium and thromboplastin activates which pathway? So, you adding thromboplastin here, so which pathway is getting activated? Extrinsic. But why is this question important? Because see, the name is thromboplastin here, and look at the APTT full form. It is activated partial thromboplastin time. So even though this is called a thromboplastin, still we are adding where? Thromboplastin in the PT, not in APTT. This is a very, very important question. It can confuse you. So understand the basic idea. Even though this is called as thromboplastin time, you don't add thromboplastin in this one. You add thromboplastin in the PT, not in APTT. So this can become confusion if you don't look at this in a straight away course. What is the answer? It is extrinsic pathway as the right answer.